The idea that if somebody has an unexplained episode of unconsciousness and they have a bite mark on their tongue, they almost always had a seizure. The exception that I've seen to this in the literature is if somebody falls during that time and they hit their chin, they may have a bite mark of the tip of their tongue. But if they have a bite mark of the lateral side of their tongue or their cheek, virtually always, if there's not a better history to explain things, they had a seizure. So the second one here actually did a similar kind of thing. They took patients, this is a Canadian study, 621 patients, and they had a history of a transient loss of consciousness, and they took from those the ones that they were sure they knew what was wrong with them. They really did have syncope or they really did have a seizure, and they threw out all the ones that they said we still really can't tell. And then they came up with this incredible scale where they gave points for everything possible. And they actually did a thing I've never heard of before. They divided the group in half, and they took the first half to develop the scale, and then they tested it against the second half. So it is sort of like a validation study and a derivation set to begin with. I don't know that you just collect all the data at the same time, but in any event, it sounds pretty valid. But then they came up with this very complex model that I don't think the point of the model is to how to add things up, but things that augured for a seizure, a cut on the tongue, a report of abnormal behavior, loss of consciousness with emotional stress, post-ictal confusion, head turning to one side, prodromal déjà vu or jamais vu. 2 points were deducted for presyncope, loss of consciousness with prolonged standing or sitting or diaphoresis. So those are the things we know clinically anyway. They stand in a long time and they're sweaty and they feel like they're going to go out, likely that's syncope. If their head turns off to the side and they can't remember anything for a long period of time, more likely a seizure. They then came up with a very complicated scale that no one has actually used, but I think it indicates those things that augur for seizure. All right, so does the benzodiazepine you choose matter? This is now basically talking about status epilepticus. How many here, their first line drug for somebody they believe is in status is lorazepam? How about diazepam? Okay, midazolam. Okay, so there's a few on each side here. So the first study here, the reason for the recommendation about lorazepam is that it comes on, its effect is almost as quick as anything, but it lasts longer. So it has a pharmacologic advantage over the others in that it will have an anti-seizure effect for longer. But in this study here, most of the people then didn't get what I call a real anticonvulsant after the first drug, which is what we really need to be doing. So if you're not going to be able to get them a second drug, yes, lorazepam probably has that small advantage, but they all work pretty well. And as one of the things that you can use midazolam, the only one that you can use IM or under the tongue or up the nose or in the rectum is midazolam that works well, and it works quickly. It also stops working quickly, so you need to be gearing up for what I would call then a real anticonvulsant after that. So where might that actually be helpful? To have something that you could administer IM or it lasts longer and they're not going to get a loading dose of medicines that we'll talk about pre-hospital. Be great if it lasted a little bit longer than till they get to you where you can give them a loading dose of something that they can't do in the field. So lorazepam, I think, would have the advantage there. So the second one was an out-of-hospital one, and they gave benzodiazepines, and then they said actually lorazepam seems to be better. Their outcome measure in this was, did they stop seizing by the time they got to the ER? Now realize that's a practical matter for them. They stopped before they got here, but it doesn't really say how long did it take them to get under control, because some would have longer transport times than others, some were seizing longer than others. It's an okay study. I think it just supports lorazepam for other things. I think I've already mentioned about midazolam. This was many years ago, I started looking at midazolam as an anticonvulsant. We had a child who used to come in maybe twice a week in status, terrible bad seizure disorder, on all kinds of meds. Mom would give the kid rectal Valium, and if it didn't work, then she'd bring him in. And this kid ran out of veins. I mean, we were doing central lines. He had no tibia left from the intraosseous stuff, all that kind of thing. And so actually, midazolam had just come out, and so we actually got a study approved to give this kid midazolam under the tongue. We didn't see him again for a long time after that. So that it actually does work. All right, so how about phenytoin loading versus fosphenytoin? How many here in their hospital only have fosphenytoin? Yeah. How many still have phenytoin that they can use, but they're discouraged from using it for reasons? No? Probably the sane Australians in here that actually can continue to use it. How many here have even heard of the term purple glove syndrome? Right. How many have ever seen one? So what happened with fosphenytoin was that the maker used to be Park Davis. Actually, this place is 1.5 miles from my house. It was Park Davis that made this. They decided to come up with fosphenytoin because the trouble with phenytoin is it's so alkaline that when you give it IV, you have to put so much buffer into it that the buffer creates the problem with rapid infusion, and people get hypotensive and syncope and all that kind of stuff. They had to buffer it so much that was a problem. So they came up with a prodrug, fosphenytoin. You can give that IV, its pH isn't bad, and then it's converted into phenytoin so you can give it faster. So this was the rationale for it, and they said, and also because there's so many people getting this purple glove syndrome when they get IV Dilantin, where their hand turns colors and they get vascular injury. And actually, some people had said that was never actually reported before they had fosphenytoin to now say this was a problem. Actually, I think I looked it up. There were 2 cases in the world's literature prior to fosphenytoin coming out, but it clearly wasn't a big problem. But in any event, they came up with fosphenytoin, and then they looked at that needs to be the way to load people. I think we need to distinguish here between IV loading of an anticonvulsant just because you want to get it there rapidly, but not because they're in status, and if they're in status, where you really need to get levels fast. And those 2 things are different. So there's a bunch of studies here about fosphenytoin and phenytoin loading. Number 5 is from Stuart Swadron. He's one of the EMA faculty. And they looked at giving people PO. They give them 200 milligrams at a time and just keep giving it to them. And how soon did they get what they discovered was a protective level, a level of 10, 6.4 hours for PO. If they gave it to them IV, given a fairly conservative loading dose, 1.3 hours. So the issue was if for some reason you thought that they needed protection, essentially 5 hours sooner, IV would be the way to go. I'm not sure what that circumstance is. That you can discharge them sooner, that's the case. So if getting them out of your ER is an issue, or they're going to go and do something else where they won't be monitored, like have a procedure or something like that, maybe that's the way to go. But otherwise, oral works. How many here use oral loading for people? They come in with low levels. You give them a big dose orally or a couple of big doses orally. You know it's going to be hours until they're actually protected, but they're chronically on it, so it's probably okay. Yeah?
I thought that there's some studies that if you're going to give them orally and you want to get a much better blood level, give the elixir.
I haven't heard that. The idea is give the elixir and it'll do better. It may be that they don't get as nauseated with it. That's one of the drawbacks to giving the oral is the nausea. So if you just want levels but you don't want speed, go PO. I thought the next one was sort of an interesting study. They said they were trying to do a cost-benefit analysis. Well, obviously, oral phenytoin costs almost nothing, and the IV does cost something, so of course it will beat it. And then they added in physician and nurse time, because obviously if it takes longer and the physician and nurse time is there, the only reason to bring this up is all of these economic studies, they take what is a fixed cost and make it a variable cost. When you look at these things, they say, well, physician and nurse time costs so many dollars per hour. Well, it's not like you can send the nurse home once you've given them the oral down. That's a fixed cost, is the nurse's salary, and in most cases, the physician's salary. So they convert these to variables and then come up with numbers, and it's still cost-effective to give oral, but I thought it only increased the cost by, $37, $17, and $60. I thought these are really cheap docs, cheap nurses, that's the only cost there. Then there's a whole series of inappropriate fosphenytoin use in the ER. And some people say, well, the only time you really need fosphenytoin is when you need it really rapidly, like in status or something like that. And so that's really the only time you need it. And they went back through their charts in the ER and said, how often did people get it when they really shouldn't have? And one of their criteria was those who were not experiencing repeated seizures or status epilepticus in the ER. Well, you only know that retrospectively from the chart review. So I think like now that they know it, they say it was inappropriate. So I kind of threw that out. But there's a lot of people who think in here, and there's a couple from Wayne State, that show you really don't need fosphenytoin. Phenytoin is just fine unless they're in status. One interesting fact I picked out of number 8 here, 60% of the patients returned to ER care within 3 months. So I don't know if it was necessarily for seizures, but these are clearly repeat visits. How about IV valproate for seizures? Anybody here using that? Interesting. I think we need to have several things in our armamentarium in the emergency department. But I'm not sure this is the next one. This next study is what I call a straw man study. They say, well, we can give IV valproate faster than IV phenytoin, so therefore it's a better drug for status epilepticus. And it is true. They can give it faster. There's a bunch of studies in here showing you can give this stuff real fast. Maybe within 3 to 5 minutes you can get doses in, and therefore it's better than phenytoin. But nobody's using phenytoin as the first-line drug for status anyway. As we mentioned here, that's a benzo. So I think if you need to give it, you can give it fast. That's kind of fun to know, but I don't think that means that it's a first-line drug for status. Then the second one was here, is it a good drug for failed status epilepticus? This was the patients had gotten a dose, this was in kids, dose of diazepam or 2 and 1 or 2 doses of phenytoin. And then they either gave them some more phenytoin or IV valproate, and which did better? IV valproate, because now you're getting a third drug on board. So I think that kind of stands to reason. Keppra, I can't pronounce anybody here using Keppra? IV or IM? You like it? I know Billy Mallon likes it at the county for a bunch of reasons. One of the things that I don't like about a lot of the newer anticonvulsants is, one, they're really no better than the old ones. With all these new drugs that came along, we were promised they are going to be better than the old stuff. There's 2 problems with most of them. One, you can't get levels. So somebody in the old days, or in the current days, if they come in and they're on phenytoin and they have a seizure, the chances are like 95% their levels are low. If they're really not low, and including their unbound phenytoin, you get a free phenytoin level is the next thing to do, then they need another drug. They're already therapeutic on it, so they need another drug. The trouble with a lot of the new drugs is you can't get levels. So if they're on Keppra and they now have a seizure, what do you tell them? Take another Keppra? Take another half a Keppra? We just don't know that kind of guideline for it. So I think it's a more of a problem for us. But 13 was IV Keppra for benzodiazepine refractory status. This is a we did it, we liked it kind of study. Another one's for status. So Billy has written out a thing here for how to do status epilepticus, and I'm not sure that any of this actually comes from the literature he's reviewed there. The one point that everybody makes is that for status epilepticus, if they're in status and they've been on an anticonvulsant, the drug of choice is the anticonvulsant that they've been on. Nothing works better. Nothing works for barbiturate withdrawal like barbiturates. You can give them all the Dilantin you want, and they're not usually going to stop. So if you can get that bit of information, that's the way to go with it. Tricky presentations of seizures and non-convulsive status. How many here have diagnosed non-convulsive status epilepticus? How many here think maybe they've seen it and missed it? I'll bet everybody's hand should be up. I think it's actually extremely difficult to diagnose. It's only if you're kind of tuned into it will you sometimes get it, and then your ability to get an EEG is sometimes part of this. So what non-convulsive status epilepticus is, there's ongoing uncontrolled electrical activity in the brain, but it doesn't have major motor manifestations. So they almost, they're almost like they're postictal sometimes. A little confused, sometimes their pupils are going up and down, sometimes they get a little bit of funny eye movement, occasionally a little twitching kind of stuff, and they present as confusion, altered mental status. And you may or may not get the history that they either had a seizure at the beginning of it, or then they have a seizure at the end of it, and then you come up with the fact that that was maybe non-convulsive. But people can be in this for days. They can get, especially old people, say they've had a remote stroke, and that's the cause for their seizure-like activity, and they present as confused, and well, you know, they're kind of old, they're kind of demented, and they're kind of acting goofy, and oh, their sodium's maybe a little low, and maybe that's it, and their CAT scan's okay, and they're doing funny stuff. I think it's extremely difficult to diagnose, to think about it, unless they have some of these giveaway funny little movements, little nystagmoid eye jerks and pupils going up and down, a little motor stuff. But that's non-convulsive status. And there's a fairly big literature on it. And in here, there's a couple of papers where, one from Duke where they had altered mental status, and then the neurology resident asked for an EEG. So now this is obviously a very selected patient population. They found it a lot. And then they tried to go back and say what were the neurologic manifestations that correlated with that, and they're the ones I've mentioned. Ocular movement abnormalities, nystagmus, hippus, and sustained eye deviation 50% of the time, that kind of stuff. So looking for that funny eye movement stuff is part of it, is part of the way to suspect this. They've said in here there's no way to diagnose this unless you can get an EEG. I'm not sure that's true, but how many in here can get an EEG in their emergency department stat? Yeah, I don't know anybody who can. In fact, I don't know any neurologists who can. Part of it used to be that they get 60 cycle interference from the lights, and there's all kinds of blowback that you get for doing it. In the patients that I've seen a couple of this and suspected it in, give them some IV lorazepam. And so when they're acting a little out of it and they're a little off and they get these funny movements, and now all of a sudden you give them a sedative and they're awake, the diagnosis is made there. You have to sort of be willing to kind of do that and have another plan if that doesn't work. But that's one way that I've done it. I want to cover the issue of EEGs in the ER because it's something I learned actually from teaching this course. A long time ago, there was an article in the abstracts on EEGs in the emergency department. And I was reviewing this and presenting it here, and this is a guy from, I think it was Louisiana, and he had done a whole bunch of EEGs in the emergency department on patients. And I was just astounded because I've had an interest in this, and I can never get anybody to do one. And he found unbelievable amounts of stuff. Non-convulsive status, things that diagnosed that the previous seizure was really alcohol withdrawal. There's apparently some signature on EEG that looks like that. All kinds of things that were just, I felt like we were all missing huge amounts of pathology by not having this. And so I presented this to an audience like this. And some guy in the audience just says, you know, this is a single author paper. Single author paper. Guy in the audience says, that guy was a doctor at my hospital. That was before they removed his medical license. He was lying about all kinds of things, billing, fraudulent billing, and all kinds of things, and he eventually got, thrown in jail for lying about other things. So it taught me a lesson about single author papers, Single author papers, you can write anything you want. You can make up data, all kinds of things. The peer review system for journals, and I do some peer review for a bunch of the journals, you can catch bad methodology, you can catch the wrong statistic being used, you can catch drawing inappropriate conclusions from the data that you've got, like we do here all the time. What you can't catch is fraud. If they list a series of numbers for blood pressure, pulse, whatever, and how many patients, you got to accept that as true. So the one thing the medical literature can't find there is fraud, as we know from that Korean study on stem cells, where they were just inventing stuff. So there's no way to catch that. The only stopgaps in that is multiple people looking at it and putting their name on it and saying, I take credit for this. And now in the good journals, and Annals is one of them, they'll list out which author was responsible for which part of this. Because a lot of these places with the ghostwriting, they'll just have somebody, some senior big name, put their name on it, and they'll say, I never saw the data. So that's one thing I learned from this on the non-convulsive status. So non-convulsive status is one of those fine things to think about. 16 was one, though, just to point up some methodology issue. A non-structured implicit chart review. For those who know Jerry Hoffman, this would put him into status epilepticus. To hear that someone would do that. And then they go back and they try to find out what were the manifestations that people had. Well, this is just to bring up the issue of the limitations of a chart review. If you get the chart and it doesn't say that they had nystagmoid eye jerks or their pupils were going up and down, what do you put? If it's silent on the issue, you don't know what that means. So this is not really something that should be subject to that. There's a couple of things in here about people who had seizures after they had gotten general anesthesia for seizures that I don't think we need to do much about. 18 is the thing I mentioned here, protracted ictal confusion in elderly patients. Some of these people are in non-convulsive status. Okay, how about this issue of the reportability of seizures? How many, for the Australians, do you folks have to report anybody to any sort of governmental body if they have a seizure or syncope or something like that? So you have to do that. So what they've gone through in here is several states, you do have mandatory reporting. California is one of them. What I thought was interesting, if you look at Articles 20, 21, and 22, 20 says 6 states have it, 21 says 7 states have it. Seems to me somebody could have done a more careful job there. But in any event, some states it's mandatory reporting, some states it's not mandatory reporting. In every state, though, this is a thing where you need to warn the patient, whether you can, that they could be out of control and that something bad could happen and that sort of thing, regardless of the statute. But the issue is the statute a good idea or not? Because this goes back to now a public policy issue, whereas we would like to think, well, if they have a condition that they could suddenly lose control of themselves, they certainly shouldn't be driving a lethal weapon, an automobile, on a crowded road where they could hurt people. But then the other side of it is, if they know that they tell you that they've had a seizure, they can't drive, in Michigan it's for 6 months, are they less likely to tell you that they've had a seizure? And so they surveyed, there's one Canadian studied here, and people say, yeah, I wouldn't tell the doctor if I had a seizure. So they're less likely to get maybe the health care that they need on that basis. So that's the balance. And then the other thing to throw in the equation is, do people with seizures have any more traffic accidents than people who don't have seizures? And the studies in here would say, no, they really don't. They're no worse than anybody else. Or this thing they'll say is, it's no worse than talking on a cell phone. It's no worse than taking an antihistamine and driving. It's no worse than being up for 20 hours and driving. And we don't restrict that, so this is unfairly prejudicing against them, and maybe people will not get health care that they might need. So those are the arguments. I don't think there's an answer for it that we know of. But the last one here, reporting epileptic drivers to licensing authorities is unnecessary and counterproductive. This is just an opinion piece, and it says exactly what I've told you there for the issues. Questions, comments, anything about seizures?